Hello, hello, everyone. Welcome, welcome, welcome. It's a beautiful Wednesday morning here on the West Coast. I think, John, you're the only one not on the West Coast with Marisa and I, right?
Hello from the East Coast.
Yeah.
I'm actually on the East Coast too.
Oh, you're on the East Coast? I thought you were in my state, California.
My practice is in California. I visit California quite often, but I'm actually
moved to Florida, right?
I did, yes.
You left us for Florida. That's like the biggest California insult. Ouch. Ouch. At least John left us for Maryland, so
That's funny.
we could stomach that. But if you leave us for Texas or Florida, we're hurt. It hits us in our soul. So.
Oh yeah.
Well, welcome everyone today for a very special episode of Ask the Experts. Liz McInville will be here in about 5 to 10 minutes, so she'll be joining with us. But I'm super excited to have you on. If you are new to the live streams, the International OCD Foundation always wants to provide the OCD and related disorders community a sense of just belonging, other people that are going through what you're going through, but also bringing on experts in the field to answer your questions and to discuss some important topics that come up in our community. So I'm super excited about today's Ask the Experts, and I'm excited about my guests. But before we jump into that, we do have some housekeeping stuff, the fun stuff, right, to get out of the way. So this live stream, a reminder that it's educational and not intended to replace therapy. So for treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. The IOCDF is not a crisis hotline, so if you are in a crisis or you're ever feeling suicidal or unsafe, please call the 988 Suicide and Crisis Hotline by dialing 988. You can also access them at 988lifeline.org or go to your local emergency room or call 911. And then lastly, we want to create a safe space and be kind and respectful to everyone. At the end of the day, we're all here to support one another. And a note that this is being broadcast on several social media platforms and it's being recorded. So, well, you see two boxes next to me, so I'm definitely not doing this alone today. And like I said, Liz McInville will be here shortly, but I'm going to introduce my guests. I'm going to let them introduce themselves a little bit more than I'm going to, but I always like to give a soft intro. So first to my right is John Hirschfield. So John Hirschfield is a licensed clinician who used to be in California. Everyone's leaving us. It is now at Sheppard Pratt in Baltimore, Maryland. I'm getting my geography better. But he's written a bunch of different books. He's been a guest on our show before and just an all-around good guy. So John, hi, welcome to the show and introduce yourself. Anything that I missed you'd like to share?
I mean, all around good guy is relative, but I thought the rest of it was pretty spot on. I direct the Center for OCD and Anxiety here at Sheppard Pratt in Towson near Baltimore, Maryland. And just always love being a guest on this program and talking to you, Chris and Marisa. It's nice to see you again. And I'm really excited to talk about the subject today. And I think it's just such a great resource for people to step in and get a better understanding of not just how OCD works clinically and what treatments are the most effective, but also a sense of what the OCD community is all about. You know, the community of clinicians, the community of people with lived experience. So I'm happy to be part of it.
Well, welcome, John. We're happy to have you back. And then Marisa, who also left us in California, is out there on the East Coast, but still treats in California. Had us on the show recently. We were able to talk about acceptance and commitment therapy, or known as ACT, really discussing how to implement that in OCD treatment. But you're back on the show with us. I know that you are the founder of Choice Therapy. So tell us a little bit more about what you got going on and introduce yourself.
Sure. So Choice Therapy is a group practice located in California. We provide individual as well as intensive therapy to youth, teens, adults. And our focus is really on integrating what works. So it includes ERP, it includes ACT, as well as other strategies that are coming out now. I have a strong emphasis on self-compassion because I do feel like shame and criticism can often be a part of OCD as well. And I think that's a big part of why I like doing these community events as well, because a part of self-compassion is common humanity, knowing you're not alone in your suffering. And so thank you for having me back.
Yes, well, thank you for coming back. That's always a nice testament to the IOCDF, to Liz and I, that people aren't like, no, we did it once, we never want to see you again. So thank you for being back. And Liz will jump on as soon as she gets here. Before we jump in, as always, I always feel like our other guest is the people watching. So definitely go ahead and introduce yourself in the chat. So you can go ahead and just say hi with whatever social media platform you're on. This is currently streaming live on the IOCDF's YouTube, Twitch, X, Twitter, I never know what to call it anymore, and Facebook. And I think we're figuring out Instagram as well. But anyways, we would love to hear from where you're from, who you're here to support. And as always, you can interact with each other in the chat. So the topic that we all wanted to bring to the table today, well, actually, Marisa, I'm going to let you kind of launch into it. I know it was something that you were passionate about. We wanted John to talk about and all of us talking about. But I think before you kind of expand on it a little bit more, I think sometimes the treatment for OCD gets a bad rap. And sometimes people think of it as like this harsh tool. I know a lot of clinicians who go into the field who don't specialize in OCD often feel like, oh my God, how can you work with clients in this way? Or, you know, OCD is really difficult to treat, or all these different kind of conversations. And as all of us know, either from lived experience or as clinicians, we see our clients do so much better. We do values-based work. We see people appreciate the work that's done, and we see our clients get better. So sometimes when there's mixed messaging, I think it frustrates me at least, because I'm like, wait, you're painting OCD treatment in such a harsh light. So can you kind of introduce the topic to our audience?
Yeah, absolutely. I mean, I think one of the reasons why I was drawn to ACT after being trained in ERP is because one of the philosophical assumptions of ACT is that people are capable of having all of their experiences, including obsessions, urges, compulsions, and still living big, beautiful lives, right? ACT and ERP are both exposure-based therapies. And the way I see it is the whole point of doing exposure-based therapies is to get good at having the stuff that's already there. So when it shows up in your life, you don't get so thrown off your game. You're like, oh, I see you there, right? And I'm going to give you a little IDK or shoulder shrug, and then go back to being present and focus on the things that are important to me. I think OCD is really good at telling people they're not capable of moving through uncertainty. They're not capable of moving through really difficult emotions or other difficult experiences. And the way I see it is, rather than trusting the mind and the story the mind gives you, trust your experience. And you won't really know what you're truly capable of unless you go there, unless you go to that scary place. And that's what exposures do, is they help people face that bully, learn that they're capable of it, while doing the things that are important to them. And I hear you with the frustration, because my heart's racing right now. And it makes me really sad to hear folks in the community talk poorly about exposure therapy. I feel like we have a professional obligation to communicate not our opinion necessarily, but what the research says. I mean, part of our opinion, right, our clinical experiences, that is important, but to also communicate what we have in the research. And exposure therapy, whether it's ACT, ERP, or other blended models of exposure therapy, have been out there for a really long time and have helped everyone. Not everyone, have helped a lot of people. Not everyone is what I was trying to say, but they have helped a lot of people. And I'm hopeful that there are other emerging treatments out there to be able to help the folks that exposure therapies haven't been helpful for. But that doesn't mean that exposure therapies are no good or a thing of the past, if you will.
I love that last line that you just said, because I do think that anytime something new's come around, I mean, I've always been a sponge. Been in this field obviously for a while, but also through my lived experience. And there's been so many new things that come out, or new adjunct treatments, or new ways to do the treatment or focuses. And I've always been a sponge and love learning. And I think what I don't understand is the need to then knock some things down, because this treatment, like you said, exposure response prevention works. The research can say up to 7 out of 10 people alone. And then if you add adjuncts to medication, that number goes up. And so it always kind of, you know, it mystifies me when people who are doing this work then turn around and talk bad about the work. So well, I want to launch a question to you first, John, a little bit, same topic, but a little bit different. How do you, as a clinician, when people have read stuff online or they hear that they're going to have to do exposures, because I think exposures get such a bad rap. To me, an exposure is like getting your life back. But I think people read it, they hear about it, they get very, very kind of like thrown off. How do you explain it to individuals with OCD that come to Shepherd Pratt who are kind of on edge or worried about ERP, whether they've heard it from people, from clinicians, or just from the general zeitgeist?
Yeah, I just learned on the internet recently that ERP is bad. I didn't know that. I've been doing it my whole career, and that it lacks in compassion, and that it's traumatizing, and I think this comes from people who have completely valid experiences attempting to implement ERP in environments, maybe an untrained clinician or a poorly trained clinician, or maybe an overtrained clinician. That can happen to someone who's like completely fused with their treatment manual and loses the humanity. And then they have these negative experiences where, well, they said I was not going to get better if I didn't do this thing, and then they made me do this thing, and it was horrible, and I don't feel better, and this exposure is bad. And I think that those are legitimate experiences, but I don't think they say much about ERP. They say a lot about that therapeutic relationship. Or about that way of approaching an ERP concept. And I have heard this from patients who come from other settings, and they come here to Shepherd Pratt, and they're very apprehensive about doing exposures because they have had these negative experiences, and they don't want to have to go through it again, because the end result is that they don't feel competent, and so it feeds into that self-criticism, self-compassion talent that they already had coming in. So I don't know. I mean, I have a model for explaining ERP that's not original and not particularly complicated, right? You have obsessions and they bother you, and you do compulsions, and then that makes you feel better, and then that reinforces that you have to keep doing them. So, I have the patient tell me, how do you treat OCD? And they'll say, well, I have to identify and eliminate the compulsions. And then I say, great, do that. And then we go from there, right? So it's not so much the model, but again, I think it comes back to the relationship, which is, I hear what you're saying. I hear the experience that you're having. You're telling me that you understand that these behaviors are not working and that you want to change them. And that you're arriving at the conclusion that you have to engage in these behaviors, right? You're compelled to, right? What does it mean to be compelled to do something? It means you don't really want to do it, but you feel like you have to. And it's going to feel much better when you're done, or something bad's going to happen if you don't. And you don't want to live this way anymore. So let's collaborate. What are the ways that you're thinking about these experiences that are leading you to the conclusion that you have to do these behaviors? We can work on that. That's the C of CBT. And then when these things are coming up and you haven't been able to catch the thinking process, and you become overwhelmed by them, infused with these stories, what are some strategies that can help you to remember to behave in a different way, so that your brain can recognize, like, oh, when we feel this way, we don't have to, we're not compelled to do this every time. We could do some other thing, right? And you build up enough of those in your head, then there's some competition. Oh, I'm triggered. I could do my compulsion. I could ignore it. I could do exposure to it. I could make a joke out of it. I could do, an ACT approach. Whatever. You get a lot of things that could come up for you that are options, instead of I must follow, what the OCD tells me to do. Right? I'm a hostage to the OCD. So I think, picking up on what you were suggesting, Chris, that this is a treatment of liberation, right? What we don't want are people that, we've beaten the OCD out of them, and they're walking away with these lower Y-box scores, and they're just like a shell of themselves because they're too afraid to do a compulsion, or they're going to get in trouble. No, we want people, leading more joyful lives and realizing, like, yeah, I'm going to have thoughts I don't like, and I'm going to have emotions that are difficult. And I'm going to try to approach them with compassion and curiosity. And I'm going to be strategic in my behavior, because my behavior is going to tell my brain ultimately what this is all about. Right? If I avoid it, my brain's going to be like, good job, that was dangerous. If I wash it, my brain's going to be, good job, that was dirty. And if I want a different outcome, I got to show it a different way.
Well said. And Marisa, hearing that, like John talking about it, I'm like, let's go. I want to do it again, right? So how do you think ERP has gotten such a bad rap? And how do you think even people who are OCD professionals, how do you think they have given it a bad rap when, like John said, it's liberation, it's getting your life back, it's re-engaging in things that you put off because of false pretenses in your brain? Why do you think it's gotten a bad rap at times? How has that been created?
Yeah, I mean, I don't know for sure, but I can throw out there.
Recently, you were supposed to like find the first bad Facebook comment about ERP and bring it to us and screenshot it and save the screen.
I know, right? I mean, I think, you know, a part of it is what John mentioned. Just like any other treatment, there can be bad ERP, right? I mean, relationship is central in therapy, as well as the tools that you're using. And so having a connected relationship with your therapist, and them being trained in being able to use ERP, use ACT in a way that is flexible and in a way that allows the client to really live their values and not necessarily live the therapist's outcome, I think is also really important. And also, as a therapist, our ability to be aware of our own processes is also really important, right? Like, how fused are we with our thoughts, right? About the treatment we do, about what outcomes should look like. Am I focused on I'm doing the right treatment or do I want to be effective, right? Am I able to do, I mean, everyone has a unique learning history, which means that I need to be able to do a functional assessment to really identify what's going to be most helpful for this client, right? And so, you know, is there an appropriate assessment going on, and are therapists able to show up in that flexible way, being aware of their own stuck points, their own rigidity, their own experiential avoidance, right? We do have some research that supports a therapist's own avoidance of experiences will impact the work in a negative way. And so the way I see it is acceptance-based work is much more than a treatment. It's a way of being, it's a way of life. And so I also, as a therapist, need to practice being flexible, being open, curious, and compassionate towards myself and in the process of therapy. That's my 2 cents.
I think there's some linguistic stuff that goes on here that's really important. So when people say something like ERP is, and when I hear these versions of ERP that are kind of bone chilling and so divorced from anything I would think of doing, even though you might technically call it an exposure, like, you know, falling out of an airplane into the middle of Alaska is an exposure. It's still not really therapy. And yeah, I sometimes get in my own head of like, do I even know how to do ERP? Like, because every time I hear ERP described, it's like, nah, that my instinct wouldn't have been to go there. Like, you know, in fact, I'll even have patients sometimes tell me, I'm not sure what we did here in session. I'm gonna commit like a kind of an ERP crime here, right? Because CBT should be very agenda oriented and structured, and I believe in that. But then there are these times when you're just working with a person, and you're teaching them about the language of their OCD, and you're engaging them in something that isn't their compulsions. And at the end of the session, they're like, what did we even do here? And I'm like, I don't know, but it wasn't compulsions. And I haven't seen you go this long without compulsion in quite a while. Maybe you could practice whatever this was out in the world and see if it generalizes. And to me, that's a very big part of what ERP is. And so when I hear ERP be associated exclusively with dumpster diving and things like that, it's unfortunate. I have to say I have some, I have compassion for people who are also kind of thinking about it that way, which is, you know, they've had this negative experience with it, and then they found another approach that they feel is working for them. And we all are challenged to be more cognitively flexible, right? We're all kind of rigid in our own ways. This is good, this is bad. This is how marketing works. This is how we're sold things, you know, so we can't help it. And so we find something that feels better than the thing that we did that we didn't like. We're going to say, well, this is better for people like me, or this is the way it should be done, and that's bad. So I don't agree with that because I'm doing the thing they're calling is bad, but I do understand why people kind of fall into those boxes and maybe can get defensive about it. I think conversations like these can be very helpful because it gives people permission to not cling so tightly to those rigid boundaries, but still also be able to say, hey, my experience was that this was unhelpful and that this is more helpful for me.
Yeah, good to see y'all. Love all of this combo. Sorry for hopping in late. I think the big piece too is just how can we make sure that we revisit or rebrand ERP? Because at the end of the day, ERP is just a therapeutic intervention that is labeled ERP, but really what it really is what any therapeutic intervention should be, whether someone has OCD or any diagnosis, which is it should be tools to be able to allow you to get back to living your life and to be able to lessen not just the symptoms, but the impact that your illness is having on your functioning. Mm-hmm. And when we think about it, like, I think sometimes we get into these nuances of like the word uncertainty or, whether somebody should do this exposure. And what I always say is that I have no idea what exposure anyone should do, only they know, right? And it's really about how can we use this human-centered approach of sitting across the couch, so to say, with our patients to figure out what do you need to get back to your life? And I will say, one thing I think that some of my patients get frustrated about is even the term like values-based ERP can be used like a bit in a wrong way, where sometimes people say things like, yeah, well, you don't need to sit on the floor and eat food. And I will have patients that are like, that's not true for me. I needed to sit on the floor and eat food on the floor to get better, right? Because of the way my OCD was showing up and the fact that like I had these triggers that eating on the floor was a values-based activity, right? Because for me, it allowed me to be able to be present and play with my toddlers who touch the ground and eat the floor and not have my rituals be involved in it. And so I say that just because I think I would love for us to talk for a little bit about kind of how sometimes values-based ERP can even be distorted to where people think that means like, sometimes I'll have patients that are like, oh, well, that doesn't feel values-based. And I'm like, well, what do you mean by that? They're like, well, that's not something I would normally do. And I'm like, okay, that's not really what we mean by values-based ERP. By values-based ERP, we're doing exposures that should get you closer to the life you want to be living. But that doesn't mean exposures aren't going to feel kind of weird sometimes or a little bit awkward or a little bit out of the norm, because when we look at that folded piece of paper, if I could create one, right, to get it back even, you have to kind of overcorrect sometimes. And so I would love, John, for you to talk a little bit about this, because I think you've done a really good job of being able to share at times of like, yes, and sometimes we do need to do those certain exposures and sometimes we don't need to. But again, it's not black and white. It's what does your patient need? And so how, as a clinician or a patient, can they assess or understand like what do they need and what does ERP look like for them?
Well, just a couple of thoughts that are coming up about overcorrection. I mean, when I'm at the gym, I'll lift like a heavy weight because I'm trying to tear my muscles in a strategic way that will cause them to rebuild and get bigger, because that's something that I want to do because I value that aspect of my physical health. But in any other context, when I see something heavy, I'm like, yeah, go pick that up for me. I don't need to pick that up. That's not in my values-based.
I'm not at the gym right now. I'm not picking it up.
That's right. So I think that there are a lot of times where we do things that when you look at them, well, I wouldn't do that. But then if you change the context up a little bit, so well, I actually would do that. Right. And so there are certain exposures where you're going above and beyond what you would normally do in everyday life for a number of reasons, right? So one of those reasons might be to increase flexibility and increase strength, and another might be to kind of more of a narrative approach of kind of showing the OCD you're not going to be bullied, right? So it's a display of what you're going to do, and the OCD is not going to like it. Another might be breaking through some of this insistence on following the rules. And so you're not eating on the floor because the floor is dirty and you're confronting being sick. You're eating on the floor because this insistence that I always do things the right way is giving my OCD the advantage, because I feel like I'm constantly doing everything wrong because I can't get it right because of the OCD. But then if I intentionally start to break some of these rules, I now realize like, hey, I don't have to do everything my OCD says. And I can remember that I broke the rules here and I broke the rules there, and be a more flexible person. So I think there's a lot of reasons to do overcorrection. On the other side of the discussion, I think there are a lot of clinicians who just get very enthused by their brilliant ideas for overcorrection, and then they end up in this power play, right? Like, I think, you need to do this like, horrifying, disgusting thing, and it's going to cure your OCD, and then it puts the patient in the perspective of thinking, well, I don't want to let them down, and they're the expert, but I really don't see how this is going to get me over home plate. So for any exposure, whatever it is, whether I like it when it's driven by the patient more than when it's driven by me. I have all kinds of wrong and crazy ideas, but if we can collaborate, what I always insist upon is like, before we're going to do anything, you're going to explain to me why this makes sense, and not like, well, I have to do what you tell me to do. I'm not going to get better. You have to convince me that you understand that making this move is going to bring more joy to your life. Maybe not immediately, because that's not how I feel about lifting a weight either. But in the long game, that's what therapy is. It's about teaching people how to live moment to moment so that they can actually feel like they're on their way to their longer term goals.
Well said. Marisa, I want to bring you in for a second. We talked a little bit about, why sometimes ERP gets a bad rap as being like harmful or problematic, or all these things for maybe people that have had poor experiences in the past. I'm glad we kind of cleared up. It was probably more with the clinician versus the modality itself. Why do you think sometimes clinicians, whether they're non-OCD clinicians that learn about ERP or OCD specific clinicians, why do you think sometimes they're putting out the messaging that ERP is harmful, or ERP is something negative or old school that we should be moving on from?
Yeah, I mean, it could be a few reasons. I'm not exactly sure why, but I mean, it could be the type of ERP training they had, the types of experiences they had in learning exposure-based treatments. It could be their own personal experiences with doing exposure-based treatments where they had some kind of negative experience. It could be that they're, hoping for, I kind of go back to that idea of like, this is the right treatment. Like, I know when I was in grad school, I was like really excited about learning about all these different modalities. I'm like, this is the one, right? Like, this is the treatment that's gonna work. And I think, with time and experience and practicing my own flexibility, I've had to step back from that and really look at, well, what if there's no right treatment? Like, what if it again is about like building that toolbox with the stuff that's supported by the research and really noticing, what is this client needing? What are their values? And which of these tools are going to actually help them get closer to it? So again, it's not about like the right, but more about what's going to be most effective for this unique person. Yeah.
Well, I wonder too
Go ahead, Chris.
Oh, I was just gonna say, I wonder too, for a lot of clinicians, when they go into training to be a therapist, they want to alleviate stress and they want to alleviate pain. And one unique challenge with OCD is, while you're working with their client, they are going to sometimes be in a stressful state to push through a difficult moment to kind of get on the other side. And so I think for some clinicians, what I've heard is that's just really challenging for them, and they want a different way. And it always reminds me of my time running gyms. There'd be so many people that cancel their gym membership and they're like, I found this diet, or I found this thing. Like, they so badly wanted this like non-stressful, challenging way to be in the shape that they want and the health that they want. And then people would come back, and it always comes down to, eating balanced meals and getting movement in is the way that we're going to get into a healthy place. And although there's all these things that come and go, because I saw so many fads come and go in the years I ran gyms, ultimately it comes down to eating well and to get some movement in. And I think sometimes therapists want to find a different way where their clients don't have to be challenged or struggling, but those moments are somebody, kind of pushing through and learning their strength. And on the other side, they're always at a better place. So I think we can't look at sometimes a client being in some struggle or having some anxiety in session as necessarily a bad thing. And like you said earlier, therapists need to sometimes check themselves and say, look, if this is hard for me, I got to work on what's going on, versus thinking, hey, this modality doesn't work for clients because I don't like to see them in some stress.
For sure. Yeah. And I think while, there are like concrete protocols out there, like I remember when I first got the ERP manual, I'm like, yes, and I'm using this is my Bible. And it was like I was a robot, with my clients. And so in the beginning, when we're learning something new, it is helpful to have a protocol to follow. And we are going to be a little bit more rigid. But through time, what we're hoping for is to also practice that flexibility and expansiveness around other tools that can be helpful for folks. And that does require more learning on our part, perhaps even us sitting with some of our own discomfort. Like when I was first doing exposure work, harm exposures in particular, I had to seek out my own consultation around it because it brought up my own anxiety, right? And so me learning to sit with that and trusting the tools that have worked for so many people is a big part of that process as well.
And this is something, we talk about all the time here, as a residential program, we are getting, we're with patients 24 hours a day. Their family is relying on us to take care of them. You're getting kind of feedback and thoughts and anxiety from the patient and the whole family system. And the thing I'm always talking to our staff about is, and myself, but candidly, my own conversations is just that is, are we taking care of ourselves? Can we tolerate discomfort? What are things that when we hear that feedback, it triggers us, it activates us, and how are we responding? Because if we're responding with urgency of, oh, this patient's really anxious, so like this makes me uncomfortable, or they can sense or see our anxiety, that impact can be detrimental versus can we model and tolerate anxiety and discomfort and these things we're trying to teach our patients. And a lot of that can't be taught in a manual. Like that happens through practice. And I think that one of the problems with ERP is not problems with ERP. I don't think there's any problems with ERP. I think one of the problems with the misconceptions of ERP is that if you haven't had a lot of specialized training and experience, it is a bit intimidating. Right? As a clinician, like you're originally taught that your job is to make people feel better, is to sit with them, is to comfort them, to help them work through these feelings and leave your office feeling empowered. And ERP, it's like, oh yeah, at times like your patients are going to be super triggered and you should do nothing about that. And you should just sit and watch it happen and tolerate it. And you're like, what? Why would I want to make someone feel worse? But when you can really understand it and you no longer are scared of that anxiety because it's a pathway to recovery, right? That also changes your perspective as a clinician. So if there's any clinicians that have thought, oh, I question ERP or I'm not sure about it, it's really important that you get quiet with yourself and that you ask the questions from seasoned clinicians or look at opportunities to get specialty training to see if part of it is just that like you're not as comfortable with it. Right? If I asked any one of us that are clinicians to go, work with patients or utilize a modality that we're not comfortable with, I bet we're going to have reservations about it, as we should, because we don't know how to do it. That's not our specialty and not our background. But the more you get to know ERP, whether, personal experience, if you're a patient listening or a professional, you really understand that this isn't just values-based. This treatment gives people their life back. And it's done in a way that can be fun. It can be creative. Yeah, at times it's a little bit quirky, but it's a part of a bigger process. You don't see it as, oh my gosh, right now I'm making a patient sit on the floor. It's like, this is getting a patient closer to being able to hug their toddler after they crawl to them, and can we see things from that lens?
There might be ways to get to the same point, like different paths to get to the same point. And that can also depend on the clinician. So I'm thinking about how we, as clinicians, regulate our empathy, right? We want to have enough empathy that when somebody's anxious, it does have an impact on us and we can feel it and we can connect with that and relate to that. But we don't want to become it such to the point that, we are in the same feared space with them. You don't want like a really anxious surgeon. You want someone who's like a little bit detached, right? Mm-hmm. But we don't want to be so detached that we appear uninterested and we can't validate that, hey, this pain is real and it makes sense to me as a human being that your pain is real. So sometimes you find yourself in situations where, okay, there's this outcome, hugging the toddler. We want to get to that outcome. And one of the things that keeps you from doing it is the toddler's on the floor and you don't want to touch things that are on the floor. And but maybe for you as an individual, you also kind of are sensitive to that. And that doesn't give you a pass, like, refer to somebody else or whatever. But there might be ways to think about that are helpful. That, your first instinct is like, oh, I'm going to have to lie down on the floor and put my face in the carpet. Then you might step back and realize like, okay, that feels like something for me. And maybe it feels like that for them. Maybe there's another way to get there, right? Or a slower pace to take. Or another thing that captures that same, I don't allow myself to feel these feelings kind of thing and changes that, how I am allowed to have these feelings. Maybe it doesn't have to even involve the floor. And that's where the collaboration part of psychotherapy really takes place. And it's still all ERP. So I think to the broader topic of this discussion about ERP being compassionate, it's specifically because of the compassion that we work so hard to figure out what's the healthy, wise, and meaningful exposure for this individual who's asking for to help them, right? To reduce their suffering. I think of ERP as very compassionate. And while I have I have compassion also for people who had a different experience, it's, when you see things online that are like, well, do this because ERP is not compassionate. It's like, that doesn't help anybody. Maybe it boosts your ego in the moment. Maybe it makes you feel safer. I mean, I get that, but how many thousands of people might be seeing that, and then it's actually keeping them from accessing the care that they need, or believing that they can, or that they're worth it.
That's so important. It's so critical that we're really thinking about that. And what I want to push you is, I said this on a webinar a long time ago, Chris, but we were with John Abramowitz, and I was saying that I would have been one of those people that said ERP doesn't work for me, but it wasn't because ERP didn't work for me. It was because I wasn't actually ready for ERP, and I wasn't doing it. I was 1 foot in and 1 foot out. And so be thoughtful too about when we use blanket statements or words of like the impact that can have, like, oh, ERP doesn't work, or ERP, right? It's like, well, wait a second. Like, I want us to understand, why isn't ERP working? Instead of saying ERP doesn't work for me, I need to go try something else, I want to understand, why did it not work? Like, let's make sure we figure that out first, because if you need a different intervention, we want to make sure we're not just guessing at another new one, right? We're being really strategic and thoughtful of what does the research and evidence show us about, if ERP didn't work, why didn't it work? Is it that you need DBT first? Is it that you need, you've got a trauma diagnosis and you need a trauma specific intervention first? Like, what's going on that we need to understand? Or is it that we weren't really doing ERP? And if that's the case, can we slow down and do readiness work? And so the last thing I want to talk about before we hop into questions, because we've got a lot and I want to make sure we get to Q&A, is, can we talk for a second about slowing down and doing readiness for ERP? I think so many clinicians who especially are like newer, or who, get trained in ERP, really have this belief or feeling like ERP means I have to jump in. I have to be giving my patients homework. We have to be doing exposures. It has to be goal focused. John, you just said that, like, you'll have a patient that'll be like, what did we just do? And it's like, oh yeah, I know, like, that's not what ERP is supposed to be, right? It's supposed to be this like structured, if you read the manual, people feel like, but I'm supposed to be doing this, I'm supposed to be doing that. And half the time I'm like, a manual, a hierarchy, like, I don't use that ever anymore. And I'm still actively doing ERP, but like, I don't use any of those things because I'm just talking with my patients and doing ERP in this patient-centered, intuitive place. But for many of our patients, even in the residential level, they are not ready for ERP yet. And that readiness work, if we don't do it appropriately, ERP will fail. So I would love for y'all to both talk about, what does readiness look like, but how hard is it as a clinician at times to do readiness? Because it is slower. It does sometimes feel not as productive. And sometimes I think that can be hard on us, because a lot of us that are CBT clinicians have our own anxiety of like, I need to get stuff done. I need to move progress forward. I need to, help this patient quicker.
And that's also driven by the fact that we're aware that these patients are spending a lot of money and spending a lot of time, or taking themselves away from their families to focus on this work. So there is that internal pressure of, I better get an outcome here, because I know how much this person's invested just to even be in the same room as myself and my team.
I think of like the slow food movement, right? It's about quality and it lasting over time versus just jumping in and getting a quick burger, right? Like, we want the work to stick. And in order for it to stick, folks need to be willing to stay in therapy for a little bit. And a part of that, I think, at least for me, is, I spend the first 6 to 7 sessions just on getting ready to do exposures. And that can include like getting really concrete with what are the person's values, like what's most important to them in life, getting really specific on what it would look like if those values were brought to life. Not only does that help me connect with the client to know like what's in their heart, it also lets me know hey, these are the kinds of exposures that we'll do then later on, right? That we want to make sure we're working towards. And when we are brainstorming exposure exercises, I have the client link each one to their values and let them know if at any point any of these exercises feel like they don't bring you closer to your values, let me know. We're going to throw it out the window, right? And so it's a very like collaborative process, checking in with the client and making sure that they really understand why we're doing this, right? And so, similar to what John was saying before, like, how is this behavior working for you, right? Like, is the compulsion helping you? Is it helping you in the short term? Is it helping you in the long term? Is it bringing you closer to those values? So we'll spend a lot of time kind of really looking at it from that perspective around what's working for me, what's not working for me in the long term, and what am I willing to kind of give up in order to get there, to get the life I want, get the life I deserve, and why that's going to mean sitting with some of those discomforts in the short term in the service of that long-term living.
Totally. All right, let's hop into questions because I know we could keep going on this, which is amazing. So Brendan, first question, would you explain how healthy coping skills such as distraction and breathing techniques, when used to directly reinforce goodness gracious, when used to directly reduce distress from obsessions, can actually reinforce them instead? John, I'm going to let you take this one.
Oh yeah, I want to take a big swing at this one because I'm not sure I agree with the statement to begin with. I think that this is a good example of nuance in ERP and how really well done ERP incorporates the stress tolerance within the exposure, and sloppy or maybe novice ERP puts everything that makes you feel better in the moment in the camp of compulsions, and you're not even going to look at it. And that's, I think, part of what can give ERP a bad name, which is like, it's just torture, and then you'll get over the torture, and then you'll know that you're better. So let's look at distraction as an example. When you do an exposure, you want to be present for that exposure. And so if you're only, you're doing an exposure, but you're intentionally trying to think about other things that you don't feel the full weight of that exposure, well, that's not exposure and response prevention. You're ruminating, you're avoiding, you're distracting, you're trying not to feel the exposure. And all you're teaching yourself in those situations is that you hate this, but we knew that going in, so there's really no point to run that experiment. However, let's say you've done an exposure, maybe a moral scrupulosity exposure or a social anxiety exposure, and after that, you notice that you want to repeat the exposure in your head and review what you did to make sure you did it correctly, or that you did the right thing, or that you didn't hurt anybody's feelings, or that they're not mad at you, or whatever it is. Now, a really good idea in that moment, rather than sitting with it, would be to go watch your favorite TV show or play your favorite video game or listen to your favorite music. And people are like, oh, but that's distraction. I'm not allowed to do that. I'm breaking the rules. I'm like, no. You have a choice between ruminating and doing something you care about. I suggest to stop ruminating. And we could call that distraction, but it's strategic. It's giving you something to do that matters, that you care about, in exchange for what your OCD wants you to do, which is, isolate yourself in a room, put your head in your hands, and try to figure out whether or not you did that exposure correctly. So that's one part of it, is there is strategic distraction used in ERP. It's not distracting you from the exposure. It's giving competition to your attention for when you want to do mental rituals. The other thing is distress tolerance and emotional regulation in general. Most people with a mental health condition have more than one mental health condition. So it's very common for someone with OCD to have depression or panic disorder or trauma or personality disorder or something else. And when you're doing exposures, it's very common to get dysregulated. Some people, when they get dysregulated, they go, wow, look at me, I'm so dysregulated. Those are the easiest people to work with, right? They get kind of anxious and they get kind of uncomfortable, and then it goes away. Some people, when they get dysregulated, it brings online other problems that you're actually not treating in that moment. And they get suicidal, or they dissociate, or they get angry, or super self-critical, or other things that take them out of the exposure, meaning they're not there, so they're not going to learn from it. So if in that moment you can smuggle in some DBT skills that have nothing to do with the content of the session, it's nothing to do with like, your hands really aren't that dirty. It has to do with regulating your breathing. It has to do with getting you back in the zone so that you can pay attention to this challenging thing in front of you. That's a good thing. Coping skills help you work through experiences. Compulsions help you get out of them. And so you can use a coping skill compulsively, but it's not inherently compulsive. If the goal is to be in the exposure and stay in the exposure, then I think it's fair game. And I do think we do ourselves a disservice when we talk about, okay, you do the exposure and anything you do that might make you feel any better is in this other category of things we're trying to resist. I think it's more nuanced than that.
Thanks, John.
Love it. I don't think we need to add on. So that's amazing. Yeah. And I think the big thing I would add on, I can't not, is just think about what's the function. That's always when I ask, what's the function? If the function is to avoid OCD because you don't think you can tolerate it, we're trying to teach you to tolerate it, right? So what is the function of the behavior, And so again, don't let blanket statements be that like all deep breathing would be bad or all right. It's like, no, what's the function of it right now? And is this actually promoting my anxiety cycle and telling me that anxiety is dangerous, I can't tolerate it, or is it allowing me to work through it? What is the function? Next question is going to be for you, Marisa. Could you revisit something from an earlier podcast, how the repetition of a word works as cognitive diffusion or demonstrates something about exposures? The example you used on that last podcast was about milk.
Okay, so I'm not going to say it always works because everyone's different. But what I will say is our relationship to language is important. Right. And so, for example, the word milk, if I'm interpreting the word milk as this awful thing and my body's responding in this way that I'm going to die or be injured in some way, and I repeat that word milk, 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 try it at home, try it on your own, repeat whatever word is really frightening for you. And I want you to notice like what actually starts to happen over time. Like for me, I start to notice, it goes from milk to these sounds over time, right? And then it starts to go to letters, right? And then I'm like, oh, wow, these letters are like strung together. I want to like milk, right? And so it goes from this thing that I'm like really terrified of and typically avoid to this thing that has sounds and letters that are just kind of strung together. And so the power of that thought, right, changes over time. Now, that's not for everyone. We can take the case for rumination, for example, right? In that case, in the first case, right, I'm using milk as a way to get closer to my fear, right? To embrace the thought that I would typically avoid. In rumination, if someone is prone to rumination, they are typically ping-ponging or spiraling on those thoughts on a regular basis. Those aren't thoughts that they're avoiding, right? If anything, what's underneath the rumination is their core fear and the feelings associated with that fear. So in the case of rumination, I would want to take somebody a little bit deeper, get to that core fear and help them connect to their feelings. But these are the little nuances that is important to consider. And again, getting back to that function of behavior as well is so important.
I want to piggyback on that actually, because I really like the way you described that, this idea that through repetition, things kind of go back to their initial core parts without their stories.
Yes.
So milk goes from the image and the fear associated with all that to the word and the letters, and then eventually that falls apart and it just becomes a sound that has no meaning. But that's really what it is, and everything else has been added onto it. Because sometimes the concept of imaginal exposure is brought into these discussions about, whether or not that's a good idea. And, I use scripting kind of strategically if it's for the right, case, the right situation. But the magic of using scripting in ERP is very similar to that, where you're telling the story that the OCD wants you to review and analyze and figure it out. And you're not doing that. You're just telling the story that the OCD is saying. But you're saying it so many times that it starts to fall back to its original position of a story, a bunch of words strung together that's supposed to mean something, but I don't know what it means. And through that repetition, you get to then have the experience of something triggering you, and then the story comes up, and you're like, oh yeah, there's the story, right? And you don't have to go into it because the repetition has put it back into its natural state, which is a bunch of ideas, and which is different from the more specific granular, I'm going to hurt the baby or I'm going to get sick or something like that.
And I want to point out the nuances that imagine if when you said milk, you're like, milk, oh, and you're like tensing and you don't want to hear the word and you don't want to think about it. And it's like, oh, now I'm scared. What does that mean? I'm making sure people are safe. And is it really mean like death or bad or whatever? That actually would reinforce it being this terrifying word, right? But it's the point of like, can we actually do an act opposite of how OCD wants us to act? When I have patients come in, and you guys have had this experience, I'm sure, but like towards the end of session, you like see your patient slowly getting more anxious, and you can tell like there's something they want to talk to you about, but they're triggered to tell you it because it'll be too hard to tell you. But also if they tell you, is it reassurance, right? And you're like, what's going on? And the way they say it, right? My answer is like, whoa, can we say that again in a more neutral stance? Like, yeah, even if it's a super taboo thought, like let's neutrally say it. Let's be less uncomfortable. But that feels opposite of what OCD wants. But again, we're trying to do the opposite of what OCD and anxiety want when it comes to how we treat it. Chris, I'm going to let you take over. I know there's a question that I would love to throw to you first, and then have you take over with questions. And the question is it okay to tell your child to push through? A therapist we've been seeing lately told my son that with OCD, you cannot push through. So now he's shutting down. So one of the things I hear is like white knuckling too. So love for you to take this on. And
yeah, thank you for the question, Aduska. What your therapist is probably saying is pushing through. A lot of times those with OCD will kind of white knuckle. So a lot of times we're kind of holding our hands close so we don't touch something bad, or we're at church, and if we're having negative thoughts, we're sort of in church just counting down the minutes till we can go, whatever the subtype is. And so what happens is some people do start to get through things. And it sounds like because of the advice of the clinician to stop doing that, he's completely shutting down. So one of the things that John said earlier on this stream that I hope you can bring back to the clinician is going from maybe some safety behaviors and white knuckling to get through life to suddenly don't do it has been too hard of a transition. And that's why your son is shutting down, because now he's like, well, I don't have any skills. What I think of all of us, our role on this live is somebody who comes to us has created ways to get through life, certain safety behaviors, whether it's closing hands and not touching something, having our mom open a door, go to multiple doctor's appointments to get our health checked out, etc. And that's how they've kind of gone through life. We, as our role, the four of us, is to give you a new set of skills, a new set of tools to get through life in a way that is not shut down and fear-based, but really kind of engaging and exciting and values-based. And so what I would talk to your clinician about is like, thank you. Yes, my son shouldn't be white knuckling and kind of pushing through just to get through, but you got to give him some new skills that he can lean on before he just takes everything off. So I think of like a transition is necessary versus just a black or white outcome. And sometimes you will, real quick, sometimes you will hear the term like push through. And what we're saying in that moment is really just like, if I'm afraid to drink from a water fountain because I'm afraid I might get a disease, sometimes clients will find it helpful, instead of sitting there and like trying to hype themselves up for 20 minutes. Sometimes they're just like, I'm just going to push through and drink the water.
Just do it. Yeah,
just do it. Right. So that's not necessarily a bad thing. But if it's more from a place of white knuckling, that's probably what your clinician, and they're just too overzealous, and there should just be a slight transition and a workup.
Yeah, I was just actually going to say that I'd want to know more about what they meant by push through, because I think that can have a lot of different implications. One might push through a workout, or one might push through feelings by suppressing them. And those are two very different situations. Totally. But I'll also throw a wrench in the works, which is there might be some variations on OCD where we do allow in safety behaviors strategically, and then the goal is to gradually reduce those safety behaviors over time. It's particularly things like disgust-based OCD. Like, okay, you're going to do this and you're going to wear gloves. If it was fear-based, I'd probably say let's not wear the gloves because that's interfering in you habituating to the fear. But if it's disgust-based and we want to actually kind of get you to engage in this behavior for right now, and like the only way you could do it is with gloves, let's see how you can kind of settle in with like coping with this uncomfortable feelings, knowing that you're wearing gloves, and then we can start experimenting with like, you know, what it's like to maybe not do it with gloves, or to do it in a different way, and kind of work your way, kind of reverse engineer it.
Yeah. And I will say too, you know, pushing through reminds me of the statement I talk a lot about, which is that we're fighting for freedom, not functioning. And I think a lot about pushing through is like a lot of individuals with OCD, we're like, we learn the basics of ERP and we're like doing exposures to function, but we might not be doing response prevention, and we're not actually getting those awesome results that you should be getting from ERP, which is like freedom and that relief and that clarity and that, you know, aha moment sort of thing. And I want to bring it back to that for a second, because I do think, you know, Chris, we talk a lot about this, but I think part of kind of what gives this sometimes that rap for ERP is that, oh, it's just this like brutal treatment, is that it's when folks are doing exposures, but not necessarily full response prevention. And they're like using it to function. And so they're doing exposure therapy, which is really brutal for someone with OCD, of like, I'm exposing myself, but I'm not actually getting these full rewards I should be getting from the treatment process. So I would love for you to talk a little bit about that, Chris, and others before we wrap up.
Yeah, no, I mean, the goal of exposures, I mean, I always try to find out what the client likes. You know, if a client really, really enjoys eating and their OCD is around, you know, getting some kind of foodborne illness, I take them to a restaurant or a place that they enjoy. But having them just expose, and you were talking about this earlier, John, like, here, eat this food and then just sit at the table and just push through and just deal with it. I mean, that sounds horrific, right? But if we're really explaining the idea of response prevention and saying like, hey, you know, Alec Pollard always talks about small e, large RP. It's like, what are you prepared to do that you're also willing to commit to the response prevention? So if us just sitting outside of the restaurant, not even eating there, but just sitting on the tables outside, that's a victory. It may not be the victory that maybe, you know, the final victory, but it's a step in the process of getting there. And so it's really giving somebody tools also of like, after you do the exposure, what do you do? I think sometimes the old manual used to say like, have them do the exposure and then just sit and stare at the wall and habituate. And I think we've all kind of realized like most clients think that's miserable. And so we don't need to do that anymore. So it's really about what do you do after the exposure that's important. You're making sure you're not doing mental rituals. You're not ruminating. You're not trying to figure things out. You're not reversing safety behaviors, counting down, but it's a very strategic process that you and the clinician are coming up with together. So when you do it, it feels like, hey, this is the bite I can chew off today, and I'll work up to something else.
Yeah, when I hear someone is shutting down, I mean, that typically tells me that they're in overwhelm zone, right? And the whole point, or my aim, is to help people get in challenge zone, right? If you're safe and comfortable, you're not learning. If you're overwhelmed, the brain doesn't learn great in that area either. So our goal is to be in challenge zone. And so if you're feeling overwhelmed, shutting down, that means we need to take a step back and really take a look at like what feels challenging, but not safe and not overwhelming. What could that look like for you?
Exactly. I'm going to ask you this quick question real quick. I think it's a good one to any three of you. Brennan, it's at 1221 from Anna. She says, how do we motivate your teen if they do not want to do ERP? The reason I wanted to have this be our last question is because I think, you know, people come in hearing, oh my God, my therapist is going to make me do a bunch of stuff I don't want to do, and it's going to be scary. And so then the teen is like, no, mom. So how do we talk to it? We could generalize it beyond teen, but if it's a loved one and they're not motivated to do the treatment, how do we have them see the value in it?
The first thing that comes up for me when I hear this is that I really want to know what the teen is talking about. Because what do they know about ERP? Like if they're saying I don't want to go do ERP, it means that they know something about ERP. I want to know what they know about it, because, you know, maybe they're right and they shouldn't do that thing. And I wouldn't object to that, right? If what they really mean is they don't want to do therapy, that's a separate issue that's worth discussing. If they're saying I'm willing to do therapy, but I'm not willing to do ERP, I think it's really important to understand from them what they think ERP is, especially with teens. ERP is not only, you know, should not only be presented from through a compassionate and culturally sensitive lens, but it should be fun. It should be, you're teaching people how to be curious, right? And some of this stuff that they're dealing with, they start as rational concerns. Nobody wants to be sick. Nobody likes feeling dirty. You know, these are like normal things that have gotten out of control because the mind has sort of labeled them as unacceptable threats and you know, things that they can't tolerate uncertainty around. And it's put them in these very isolated places where we really want to teach them is like, isn't it wild that your mind does that? Like, it's kind of interesting. What's that about, right? Mm-hmm. That curiosity of like, you know, what's it like to do things that are different and kind of make you feel a little bit odd, and like, you know, that's how they're going to learn things as adults. It's going to be so applicable to so many different things, you know, relationships, career, things like that. So if the kid's starting from a perspective of like, that's bad, I don't want to do it, there's a lack of curiosity there that I would really want to tap into as a clinician. The question is from a parent, how do you get your kid to get over the the speed bump of actually getting in front of a therapist that would have that conversation with them? That's I think we need more than 30 seconds for that answer, but I'll defer to the rest of the panel.
I mean, the thing, yes, and I guess the other thing that I would add to that is just finding out what is fun for them, right? Because, for one kid, it may be going to concerts. For others, it's getting back on the soccer team. What specifically is fun for your kiddo? What drives them? What motivates them? What brings them joy? And I would say use that to help motivate them to do this hard stuff, right? Because why bother doing exposures unless you're doing it for something that's really meaningful? Right?
Yeah. And I saw somebody put in the chat, like, ERP is uncomfortable. And once again, I go back to it. That's what I always get concerned about, because then people want to find a new modality and throw ERP out. And I think there's other adjuncts, and I think there's other up and comings that people might find connect with them better. But before you're kind of tossing out something that's been so helpful for so many people, I think when it says ERP is uncomfortable, let's say somebody hasn't visited their nephew for the first 2 years of your nephew's life because of POCD based obsessions. It is going to be uncomfortable to see your nephew, but think about what that's going to be like. And look, if it takes you 6 months to work up to that, maybe you just write down his name for the first 3 sessions just to get comfortable hearing his name, that's okay too. So it's tolerable discomfort. I always want to put that out there, because I think people think of extremes.
And anything great in life is uncomfortable. Think about anything you've accomplished in your life, whether it's having a baby, there's physical and emotional pain with that one, right? Getting a grad degree, right? Anything great that you've ever accomplished will have some discomfort. Those are growing pains. That's how we grow.
Yeah, I was doing a talk the other day to moms, and they're like, but our kids are at college now, how do we make sure they don't struggle? I was like, you don't. And in fact, you encourage the struggle, right? What do you want to teach your kids? In the words of Kim Quinlan, like, they can do hard things, right? We want to teach ourselves, our family members, our friends. And if you were to ask me, I believe that is our biggest problem in society right now, is that that in general, as a society, right, our tolerance for distress seems so low. And we have this thought process that, like, oh, I should never struggle. I should never have to experience distress. I mean, think about it. People can't even sit at a stoplight anymore without pulling out their phone to stay distracted and busy. No, let's learn to tolerate being uncomfortable, feeling a little bit distressed, and being okay with it. And the best way as a therapist, as a parent, to teach other people to be able to do that is to model that ourselves, right? When we feel distress, can we maybe even talk about it or share it, but walk through it versus panic and respond to it. Trying to teach my husband that about getting to the airport 3 hours early. He's like 3 hours out, like he's in a full-blown panic. You do this every time, Liz. I'm like, yeah. And I'm not going to respond to your anxiety because I don't need to get there 3 hours early. If you do, drive yourself, but not going to respond to that. This has been awesome. This is, I think there's clearly so many questions, so much great engagement, and such a need for more and more of these as we continue to break the stigma. I feel like for a long time we had to break the stigma of what is OCD, which we're still doing. But I also think we have to break the stigma of what does treatment look like, and that it's not this brutal, terrifying thing. It should be this rewarding, engaging, sometimes scary, hard in the process, exposure, experiment, whatever you want to call it, that gets you closer to the life you want to be living.
And that, if we can end on this note, because I think it's important for the broader discussion, there may be things that aren't ERP that you find really effective, and they may be really effective for a lot of people, and they may be worth exploring. But I think when you frame something as kinder or gentler than ERP, that's sort of like an immediate red flag for me, or red herring, whatever the expression is, right? Because I have not experienced either receiving or giving ERP to lack in kindness or gentleness. Maybe lacking in comfort, but not kindness or gentleness or compassion. So whatever the other thing is that you're like, oh, this is kinder than OCD. You should do this because it's gentler than OCD. that's saying that you know everything that there is to know about ERP, and I think that that's doing it's misinformed.
Marisa, any final thoughts? Thank you, John.
I mean, in the same way that I'm trying to teach my son to embrace his fears, my hope is like my stance as a therapist is to send the message that this is hard, life is hard, growth is hard, and you can do this. And so I'm reflecting on like, how am I showing up at the session? Am I sending my clients a message that they got this, while validating this is hard and going slow and being kind, because even ERP can be done in a kind, compassionate way.
Well said. Well, thank you so much for being our guest today. Liz and I always appreciate our guests, and we really, really appreciated you on the show today, Marisa and John. I was about to say your names together, Jerisa. Just like, I guess I was looking at both.
Never know.
I'm like, I think they're both married, so that's not good. I didn't do that. But thank y'all so much for being on here. We really appreciate the topic. For the people whose questions we didn't get to, that's what you saw me doing furiously. I put them on our big question list, and Liz and I have to do a mailbag real quick. But thank you so much. We'd love to have you back on. And Liz, give us the final word.
Yeah, next week will be Research Roundtable, so we will be out, but we will see you guys in 2 weeks. I'm really excited about our continued webinars and ideas and thoughts and content that we're going to bring y'all's way. Please make sure to go to www.iocdf.org/peace of mind if you want to upload thoughts, questions, ideas for content, or things you want to make sure we cover and discuss. Thank you guys, and remember, ERP is warm, it is gentle, and it should be life-changing and life-saving.
Bye.
Thanks.
Ooh, I love the new graphic, Brennan.
I know. We're getting fancy up in here. It's because we have John and Marisa. They were like, bring out the good